same patient with 3 patterns from 5 patients, and it means that we need to look into the personalized data, need personalized analysis. This is why we started looking on each patient separately, and here we have the data for patient A. So here we have 9 out of 30 symptoms. This patient monitored 5 cycles for each symptom. Just to understand how are we looking at it, if we're looking on the abdominal cramping, we see it's more dominant on the menstruation, ovulation, and PMS patterns. If you're looking at lower back pain, it's more consistent through the cycle, and the fatigue is the most impactful symptom. But this is just the first step in the analysis that we're doing. It's still work in progress. The next step, we start looking for detecting patterns, and then to have a machine learning that can detect patterns for each patient separately. Next, we define the idea of symptom burden and symptom group burden. So symptom burden is the percentage of symptomatic days we have per cycle. So here again, we have 5 symptoms for one patient. We're looking on all 5 of them: heartburn, nausea, wasting, cramping, and feeling of heaviness. And in the graph, we have the symptomatic day on the y-axis, the number of cycles we have on the x-axis, which is 8. And what we see is that cramping, for example, the patients suffer from 12 to 33% of days of the cycle. It's about 3 to 9 days, depending on the length of the cycle. Waist pain, she can suffer from 15 to 55% of days in the cycle. But if you're going to look on symptom group burden, going back to the METRA, so now we see that all 5 of them are part of the gastrosinus symptom in the HLGD group. This is the black line. And the way we define it is the percentage of symptomatic days per cycle from all symptoms under the group HLGD group. And here we see that it's 62 to 100% symptomatic days, meaning the patient is suffering from a pain or discomfort almost every day of the cycle. So this is a completely different way to look at it per symptom or per group. The last thing is that we have a framework for evaluating treatment effectiveness. This is still work in progress. It's the same symptoms before. It's based on the symptom burden score we had in the previous slide, but now we're taking the frequency and we're adding the severity. And the idea is, again, that we can explore the treatment effect from symptom level all the way to the system body, and we can also see the correlation between the two, the different body systems. And the reason we still work in progress is because now we need to start thinking, how can we improve the visualization of a result like that physician and patient can go over it together in 15 minutes appointment time. So I presented here a digital framework for personalized structured symptom monitoring with personal pain scale. The importance of that is to transform the subjective data into an objective data that we can actually work on, then the METRA that help us understand the multi-systemic effect of this disease, how much it changes between patients, and the high variability between that emphasize again the need for personalized long-term monitoring. So our next step is to apply this platform in a real clinical setting, where the idea is to see if the platform can support physicians to making more personalized treatment decisions. So we say decision supporting tool for physician. We're going to have 2 pilots with Dr. Michael Lewis from New York Presbyterian and Dr. Tara Neshi-Rizan from NYU Langone, and we are actively looking for new physicians who would like to collaborate with us. Thank you, and feel free to reach out.
Thank you very much for the presentation. Unfortunately, your time is over, so we couldn't accept any questions. So, as to remind, each presenters have 8 minutes for presentation and 2 minutes for the discussion. So, next presenter will be announced by my colleague.
Our next presenter is Dr. Maryam Mirzaie, speaking about selective appendectomy in patients undergoing minimally invasive surgery for endometriosis.
Okay, good afternoon, everyone. Also, I'm not a doctor, so I just have to say that. How do I? Oh, I don't know where my title is. Are these the ones I sent? Yeah. I don't know what the title is. Maybe I'll use my own.
Yeah.
Actually, maybe it doesn't matter, honestly. I'll just read the title. It's okay. Thank you. Okay, good afternoon, everyone. My name is Maryam, and I have been doing research with Dr. Nezhat for a little over a year now, of Dr. Camran Nezhat. And today I'm going to be presenting a paper that we published at the end of last year regarding the prevalence of appendiceal pathology in patients with endometriosis, and also the safety of performing the dual procedure. So as we know, endometriosis is chronic and it's systemic. So not only does it affect reproductive organs, but also neighboring structures. And a central clinical challenge when dealing with the appendix is that appendiceal disease is quite difficult to identify both preoperatively and intraoperatively. So that means that visual inspection alone, it's not accurate enough and disease can be missed. So what makes this an issue to us is that appendiceal abnormalities can create this sort of diagnostic ambiguity through its overlapping symptoms with endometriosis. And ultimately, it was this ambiguity that motivated this study and led us to two main questions. The first one regarding prevalence. So what is the prevalence of appendiceal abnormalities in patients with endometriosis? And then safety. So what was the complication rate when the concurrent procedures were taking place? So this was a retrospective cohort study. Any patient who underwent an appendectomy in this time frame was included. And their initial reason for surgery was either primarily pelvic pain or infertility. So during surgery, the appendix was carefully inspected for those following criteria. And let's see, I have images here. These are from Dr. Camran Nezhat's case. So on the left, we have endo and a little bit of inflammation. And then on the right, we have some more endo. And then post-operative outcomes were assessed over a 6-month follow-up period. Okay, so our analysis of interest looked into whether this appendiceal pathology differed or maybe correlated according to the severity of the endometriosis. So, of the 556 cases in that time frame, around 42% of them underwent an appendectomy. Of those 236, 100% of them did have endometriosis, with most of them being severe cases. And 91% of that 236, so I think it was like 216 of them, presented with abnormal appendiceal pathology. So on the screen, let's see. So these are the categories of the pathology. And our most common one was adhesions at around 60%. And then one of our most notable findings was actually there were 3 cases with neuroendocrine tumors, and one of them was malignant. And then when we analyzed this pathology with the endometriosis stage, we actually did not find any significance between high and low stages. However, there was a near significant association between like classic endometriosis at the appendix and more severe cases. So I think stage 3, stage 4. And then this just suggests that involvement of the appendix is more common, or could be more common, in more severe cases. Okay, in terms of safety, there were no intraoperative complications. There was one readmission 2 weeks after they were readmitted for a fever and then discharged after 24 hours. So it's unlikely that this was related to the procedure, but I'm mentioning it anyway. Okay, so why do we care about this? So appendiceal pathology and endometriosis, it's more common than we think. And also the pathology, it's not just limited to classic appendiceal endometriosis, but there are many others that I had listed. And secondly, the appendix should be carefully inspected and evaluated at the time of surgery for any sort of suspicious findings. And then if present, then the surgeon could consider doing an appendectomy. And then going back to those 3 neuroendocrine tumor cases, pathology, it can be hidden or it can be internal. So careful inspection and removing the appendix could potentially reduce future diagnostic uncertainty. But all that being said, our study is not arguing for routine prophylactic appendectomy in every patient with endometriosis. I think the decision should remain at the surgeon's discretion and rest individualized per patient. and the surgeon will weigh the potential benefits against the risk, even though our risks were basically zero. Limitations. So this was a single center study, which prevents us from generalizing our results. And also it was a high volume referral center. So a lot of our cases were more severe, and this probably explains why we had such a high observed prevalence of pathology. So I just wanted to mention that. And as for future work, oh, good, it's here. Okay. Okay, I think it would be interesting to see which intraoperative finding correlated to the pathological finding. I know that might not make sense, but which visual cue, for example, like Dr. Camran Nezhat would see during surgery, related to what was found in the pathology report 2 weeks after, or whenever we get them back. Okay, to reiterate, about 92% of our sample who had an appendectomy presented with abnormal appendiceal pathology, with one likely unrelated post-op readmission. And our study shows that the appendix should not be overlooked during endo surgeries, and careful assessment can play an important role in surgical management. And thank you.
Thank you very much for this nice presentation. We have time for discussion. Is there any questions or comments on this very interesting study?
Thank God. Okay, great. Bye.
Okay. We will now to the next presentation, which is presented by Dr. Zahra Najmi. And the subject is new classification system for endometriosis and adenomyosis staging. Stage is yours.
Okay. So good afternoon, everyone. My name is Zahra Najmi from Dr. Camran Institute, and today I'm going to present a new classification system for endometriosis developed by Dr. Camran in 2025. Before starting my presentation, I wanted to thank you, the scientific committee of the conference, for the great meeting, and also appreciate for the opportunity of presenting today. So let's start with the disclosure. Endometriosis is a common disease affecting 1 out of 10 women in reproductive age, and of course the adolescent group. It can cause chronic pelvic pain, infertility, and reduced quality of life. There are different classification systems are used currently for endometriosis, and each of them definitely has their own limitations and advantages, starting from ASRM, introduced in 1982. It's usually evaluates the peritoneal, ovarian, and tubal adhesions, stage from 1 to 4. It's widely adopted and simply to use. Another classification system is Asian classification system, introduced in 2003. It evaluates the endometriosis distribution in different A, B, C components, and can create a good mapping of DIE in detail and could help in surgical planning. EFI, or endometriosis fertility index, that is another staging system for endometriosis, usually focused on fertility and pregnancy prediction after surgery, is scored the fertility prognosis from 0 to 10. AGL has another classification system, helps surgeons to guide OR planning and resource allocation. And finally, we have IDEA, International Deep Endometriosis Analysis, is an ultrasound-based DIE and ovarian mapping, evaluates for a kind of help for kind of standardized preoperative ultrasound terminology. And now we have our new classification system developed by Dr. Camran, AGE classification system. I can go for the next. This classification system has 2 key innovations which set this system completely apart from the others. The first one is integrating with the adenomyosis. According to the molecular evidence, confirmed that adenomyosis and endometriosis has the same or this could be the same disease and sharing the same molecular and histopathology characteristics. Up to 50% of endometriosis patients have adenomyosis simultaneously, and up to 70% of adenomyosis patients have endometriosis. So adenomyosis independently impacts surgical outcome and also treatment response. And by excluding adenomyosis, patients with both disease are systematically understaged. And that's why these new classification systems try to integrate adenomyosis as a component of staging, endometriosis staging. The second key innovation is separating genital and extragenital endometriosis from the others. As what we have in current staging system, we cannot differentiate these two anatomical locations. For example, if you imagine a stage 4 of endometriosis in the ASRM staging system, bilateral variant cyst could be stage 4, and also rectovaginal DIE or stage 4. Basically, the same stage for two completely different situations, different surgical planning, and of course, different surgical outcomes. So this classification system, this AGE classification system, separates genital and endometriosis, extragenital endometriosis, for more precise surgical planning and better prognosis prediction. As a system overview, this system has three independent components, each stage from 1 to 4. A for adenomyosis, evaluating uterine wall thickness, junctional zone thickness, and focal lesions or adenomyomas. Genital, G for genital endometriosis, evaluating ovaries, fallopian tubes, cervix, vulva, and vagina. And E for extragenital endometriosis, evaluating bladder, bowel, ureter, rectovaginal septum, pelvic side wall, and diaphragm. In more details, adenomyosis could be staged by preoperative ultrasound or MRI finding, including data about uterine wall thickness, junctional wall thickening, or focal involvement. We can use each of them or a combination of them, and the highest score across all of them could be the final staging of A or adenomyosis component. It's a little bit detailed. For example, for diffuse uterine wall thickness, we consider stage 1 when we have just one wall involvement and the thickness lower than 20 millimeter, and stage 4 for two wall involvement, both of them more than 30 millimeter, or a kind of global uterine enlargement. Or, for example, for focal adenomyosis, one lesion less than 10 millimeters would be stage 1, and for stage 4, more than 2 lesions over 20 millimeters. For genital endometriosis, we will start evaluating all the ovaries, all the endometriosis lesions, and the ovary, fallopian tube, cervix, vulva, and vagina. And also evaluate the adhesions. So it will be staged from 1, 2, 3, 4. Minimal stage 1 could be considered for patients who has involvement less than 6 spots of endometriosis with no adhesions or at least filmy adhesions and no endometriomas. Stage 2 will be considered for patients with 6 to 10 spots of endometriosis, no or filmy adhesions, and no endometriomas. And stage 3 or moderate, they have more than 10 spots of endometriosis in genital organs, none or filmy adhesions, and a single endometrioma less than 3 centimeters. And finally, for the stage 4, the number of spots could be completely variable. The adhesions could be thick or dense adhesions, or considered as stage 4 or severe, and endometrioma could be bilateral or one more than 3 centimeters. For extragenital endometriosis, we'll be evaluating bladder, bowel, ureter, rectovaginal septum, pelvic side wall, diaphragm, and appendix for any endometriosis lesions. This component also staged from 1 to 4, minimal with spots lower than 6, depth of penetration lower than 5 millimeters. The mild one, 6 to 10, lower than 5 millimeters. Moderate, more than 10 spots, lower than 5 millimeters. And finally, stage 4 could have completely variable spot counts, but the depth of penetration is definitely more than 5 millimeter. Any penetration to mucosa or muscularis penetration could considered as stage 4 of extragenital endometriosis. Any partial or complete obliteration of cul-de-sac considered as stage 4, and any irregular bowel obstruction or any organ compromise will be considered as stage 4. This staging system can be easily recorded in these 3 components. For example, A1, G2, B0 means minimal adenomyosis, mild genital endometriosis, and no extragenital endometriosis. The 3 components staging system creates a kind of shared language across a specialty, and a single designation can convey complete disease distribution across those 3 anatomical locations in a second, and every clinician reading the same AGCES score arrive at the same understanding of the disease. Look at these 2 other samples for examples. For example, in the second one, stage 4 is in genital endometriosis, in the other one, stage 4 in extragenital, and completely they have the different outcome and surgical planning. And finally, to support widespread use of this classification system, we have developed 2 tools. One, operative report sheet, which is a kind of PDF form. You can have it to ensure the consistent staging system used across all surgeons. And we also have a web application, which can kind of a real-time interactive staging calculator and automated operative report generator, which could be helpful for surgeons. Most of them are available here. The first one is the operative report sheet according to this staging, and the second one is the web application sheet. And finally, for the future direction, we are planning to validate this staging system as a predictor of surgical complexity, preoperative complication, and probably the outcome of fertility and symptom improvement. And finally, final take-home message, adenomyosis belong in endometriosis staging, and separating genital and extragenital endometriosis from each other could help for better decision-making in endometriosis.
Thank you very much. We will get one question from the audience. If not, I can ask something to you. Does this new classification system bring some advances to your daily practice managing endometriosis? To the microphone.
I'm sorry, please.
Any advances, I mean, any practical benefits for your daily management of
of course. One important point about this staging system is integration of adenomyosis. Definitely people who have adenomyosis and endometriosis, sometimes they're understage their disease, and some of the signs and symptoms are completely related to their adenomyosis. So we decided to integrate both of them together in one staging system so people can have a better view of description of the disease inside of this. And yes, this is our future plan to validate how it can help for our future clinical use, and how we can validate it with the outcome of our surgery, symptom improvement, and also how it will be correlated with the complexity of the surgery.
Thank you very much. Thank you. Now, we are moving to a very innovative study presented by Dr. Gaby Moawad, which is diagnostic performance of the salivary miRNA signature for endometriosis among women presenting with infertility.
Thank you very much. So I'll be speaking about the salivary testing using microRNA to diagnose endometriosis in an infertility setting. Despite all the efforts that we've been doing on all aspects, media campaign, practitioner training, there is no reduction in the delay of diagnosis of endometriosis. So that's why the conventional methods that we've been using, laparoscopy, radiology, did not do enough for us. So there was an urgent need to have a validated non-invasive biomarker to accurately diagnose endometriosis. I'm not going to go all over again how much endometriosis is affecting, the prevalence, but we know nowadays more and more that unexplained infertility is probably due 50% to endometriosis. So the early diagnosis is imperative, especially in that subset group of patients, the infertile patients, to create a better strategy to preserve organ and fertility. And we know that endometriosis, even superficial endometriosis, can affect infertility by multiple mechanisms, affecting the inflammation in the body, by the macrophages doing a poor function inside the peritoneum, also affecting the egg quality, also affecting the receptivity and the endometrium and other genetic factors. So from a study that looked at 4 million infertile patients, it highlights the accurate classification to improve fertility management outcome. So we present the Endometriosis saliva test study, which is a subgroup analysis from a larger study that was published in the New England Journal of Medicine. And this is a prospective multi-center study. And for the main key or the main objective of the study is to evaluate the diagnostic performance of the salivary miRNA test across 3 clinically relevant populations. First subgroup is infertile patient versus all controls. Second subgroup, infertile endometriosis patients versus nulliparous controls. And the third subgroup, infertile patient with superficial peritoneal endometriosis or superficial with deeply infiltrative versus control. And the key points were to look at accuracy, sensitivity, specificity, positive and negative predictive values. For those who you don't know about the microRNA, these are smaller nucleotides, 22 usually nucleotide in length, that serves as a post-transcriptional regulator of gene expression. And in endometriosis, there was specific panels of those microRNA that were identified. And for the Endometriosis salivary test, it was 109 different microRNA that were identified and tested. So the study is a prospective study, as I mentioned. It's a multi-centric study. We included all patients from 18 to 43 across 17 centers in Europe. And then those are university hospitals, general hospitals, imaging centers, gynecology practices. And the endometriosis was diagnosed through standard techniques, either by imaging or laparoscopy or both. So the controls in the study were those in whom endometriosis was definitely excluded through laparoscopy. It's not a control from the general population that could be biased by having endometriosis undiagnosed. So again, those 3 group analysis subgroups that we talked about, the infertile are diagnosed based on the normal classification of infertility, which is 12 months of unprotected intercourse. The first analysis comparing the infertile endometriosis patients, 182 patients compared to controls, the 222. And this is probably represents what happens in real life. The second subgroup, when comparing infertile with nulliparous only, is just to reduce the confounding factor of parity. And the third sub-analysis was focusing on superficial peritoneal and superficial with deeply infiltrative to test the performance in most diagnostically challenging stages. So when we look at the study, the demographics, we see age older in the endo subgroup, the BMI is comparable. I want you to look at the symptoms. The symptoms could be overlapping. So clinical diagnosis is not predictable at a high accuracy for endometriosis. That's why patients who might have symptoms that are basic symptoms for endometriosis might not truly have endometriosis. So leaving the diagnosis on clinically alone is not accurate. So when we looked at the first subgroup analysis, we see that the test demonstrated outstanding diagnostic performance with an accuracy 95.3%, sensitivity 96.7%, specificity in the 90s, but the likelihood ratio, it's 16 times more accurate than laparoscopy. So this robust performance in real-world setting, which is the first subgroup comparing the patients with infertility with endometriosis to controls, shows that when we have the infertility status unknown, which is 50% due to endometriosis, this test would serve you as a non-invasive diagnostics test to establish a strategy for those patients who are diagnosed with endometriosis and then enable them to protect their fertility or have options. When we look at the second subgroup analysis where we remove the parity as a confounding factor, we see that test even outperforming with a high accuracy, sensitivity, specificity, and even better likelihood ratio, 30.6. So this shows you that even parity as a confounding factor would not reduce the accuracy and the sensitivity of this test. And when we do the other challenging diagnostic setting, which is comparing superficial endometriosis and superficial plus deeply infiltrative endometriosis, during the disease, the test maintained high sensitivity, high specificity, positive predictive value and negative predictive value, and likelihood ratio that is highly sensitive. So now we are on a verge of seeing something that might help us counsel our patient better, reduce the diagnostic delay, and the most important, it's non-invasive and it does not require a skill or anything to be done. So for some surgeons who know endometriosis is very tricky even to the eyes. Unless you're an experienced surgeon who've seen a lot of endometriosis, many times we see negative laparoscopy where actually patients would have the disease. So that's going to remove the error, human error, into creating a more confident pathway for these patients with infertility. So in conclusion, the salivary testing showed high accuracy across all diseases subgroup in this study, supporting its clinical utility in even heterogeneous infertile population. I believe this is the pathway to the next generation diagnostic to enable our patients to have a fair diagnosis, especially with a chronic non-curable disease. And the clinical impact is going to reduce our diagnostic delay and limit the medical wandering, medical gaslighting, and optimized treatment pathways for our patients. Thank you.
Thank you very much for this excellent presentation. Are there questions? So please, Professor.
Well, have you tested this against patients that definitely don't have endometriosis?
Yes, these are the controls where patients confirm no endometriosis with laparoscopy.
So what would those numbers be in those patients? 0?
The percentage of the positive predictive value.
The positive predictive value, if you can see, it was in the 90s, 98, 93, and then 80 in patients with superficial
So that's
peritoneal.
predicting that they don't have endometriosis?
Positive predictive value, they predict that they have endometriosis. Negative predictive value,
I understand, but what about a series of patients that definitely don't have endometriosis? They have no symptoms, they're not infertile, just a normal control.
yes,
Those numbers-
there is an ongoing testing around that because we believe the prevalence of endometriosis is far higher than the 10%. And then we see when we do a large-scale population through that testing, we're going to realize that there will be patients with silent endometriosis, as we say.
Wonderful, Gaby, Dr. Moawad. Excellent talk. How does this saliva test compare to the other saliva tests available on the market?
No, this is the first test that combines artificial intelligence and the microRNA testing because they created algorithm through those microRNA 109 signatures that provides an accurate, far more accurate than the other saliva test that is present because the other saliva test looks at the inflammatory mediators out of endometriosis and it's not as specific or signature microRNA specific to endometriosis.
The second question is, what were the exclusion criteria? Like, for example, the other tests in France, they excluded anybody younger than 18.
Yes, here the inclusion criteria is between 18 and 43, and there is an ongoing study on adolescent endometriosis, which we believe this is a greater subpopulation that needs to be studied accurately because this is when the work will start for chronic diseases.
Perfect. That was my request. Thank you very much.
One question. Thank you for your talk. I was just wondering if you could comment on the prevalence of endometriosis in this specific cohort.
This is a well-selected cohort because what we've done, we collected all the patients. Those patients were either diagnosed by symptoms or by MRI or by laparoscopy. All of them underwent laparoscopy to exclude endometriosis. So this is not a general population cohort where we tested those populations to identify the prevalence. This was a cohort meant to study the accuracy of those tests in different settings. So we cannot exclude from this the prevalence of endometriosis.
So we don't have a prevalence for this.
No, the prevalence of endometriosis will be studied as if you have 100 consecutive women coming, whether with symptoms or no symptoms, and we get them tested. And when we found out the percentage, that could reflect the prevalence on a larger scale with appropriate statistical stuff. But we believe prevalence is going to be way higher than 10%.
Thank you.
Last question.
My question is, it's extremely interesting study and very well put together. My question is, will this test, let's say it becomes clinically available, will this test?
It is approved by CMS, by the way, but still not marketed in the
Exactly.
US. So this is what's going to happen.
First time I heard about this. I've done a lot of saliva testing in various other scenarios. Will this test, I mean, none of them were actionable. Do you consider this will be an actionable test? That means as soon as I find a positive test, as you said, it's very high PPV, will that be something that you say, okay, next step is laparoscopy, the algorithm of yours? Okay, we have symptoms, or general population, we do a test, and then they all have to go for laparoscopy or other confirmatory test.
So for us, it's very highly accurate and specific. And then the importance of this test is the positive predictive value is elevated. So when we talk about patients who score positive for this, first reducing the diagnostic, it doesn't mean we need to do action because sometimes we have an endometrioma of 2 centimeters. Patients don't have any symptoms. We follow them and they don't need anything. For me, one of the biggest pet fears of endometriosis patients is the delay in diagnosis and the gaslighting. So, and then understanding what are their options, educating patients, partnering with them to create a better way of understanding their body and managing their symptoms. We know if we keep putting endometriosis in the corner of the pelvis, we're not going to be able to treat patients. Nowadays, we know the inflammatory impact on multiple systems in the body. So this test will shorten the time to diagnosis, will reduce the guidelighting, and will give patients more cleaner strategy to do about their body, whether it is laparoscopy, whether it is functional medicine, whether it is understanding other symptoms not related to the pelvis, whether it is infertility. So this is going to be an open gate for patients to be empowered, to understand more about their conditions and help treating them and save their organs.
Thank you. Thank you very much for the presentation.
Thank you. Our next talk is by Jacqueline Lamboy, Multidisciplinary Approach to Bowel Endometriosis, Integrating Preoperative Imaging with Ultrasound and Sigmoidoscopy.
In this video, we present an atypical presentation of bowel endometriosis and highlight the multidisciplinary approach with the utilization of ultrasound and flexible stimuloscopy for diagnosis and surgical planning. Authors have no disclosures. Bowel endometriosis is a form of deep infiltrating endometriosis, representing approximately 4 to 37% of all endometriosis cases. It most commonly affects the rectum and sigmoid colon and typically presents with symptoms of dysmenorrhea, dyspareunia, and dysesthesia. Some may also experience catamenial diarrhea and hematochezia. This case involves a 43-year-old female who initially presented to an outside hospital with rectal pain. She was found to have a 5-centimeter rectal and uterine mass on imaging concerning her malignancy, prompting a referral to colorectal and GYN oncology. Further workup demonstrated a normal CEA and a mildly elevated CA-125. MRI illustrated a 6-centimeter spiculated rectal mass along the anterior surface of the rectum with extramural extension. She was clinically staged T4B and 0. Colonoscopy revealed a partially obstructing 8-centimeter mass on the anterior rectal wall. The biopsy results showed normal rectal mucosa. The patient was then counseled on surgical evaluation, but elected to seek a second opinion with another colorectal surgeon before proceeding. She underwent repeat colonoscopy, which confirmed the presence of anterior rectal wall mass, an endoscopic ultrasound with transrectal biopsy, which showed endometriosis. She was then referred to our mixing for further management. She reported a long-standing history of pelvic pain and dysmenorrhea, along with other symptoms consistent with bowel endometriosis. Examination revealed an enlarged and mobile uterus with nodularity in the posterior fornix. A transvaginal ultrasound was performed that showed a non-mobile enlarged uterus, as well as a 7-centimeter hyperechoic anterior bowel lesion with infiltration of the uterosacral ligaments in posterior uterus, as illustrated here. After comprehensive counseling with a multidisciplinary approach, she was consented for a robotic-assisted hysterectomy, resection of endometriosis, possible partial proctectomy, divertinostomy, and laparoscopic-assisted bowel resection as a co-case with our colorectal surgical team. Initial laparoscopic evaluation of the pelvis revealed an obliterated posterior cul-de-sac with the rectosigmoid bowel densely adherent to the posterior uterus. Our surgical approach was based on the systemic social technique and began with mobilization of the sigmoid colon and ovaries. Ureteral lysis was then performed to aid with preventing ureteral injury, restore normal pelvic anatomy, and aid in isolation of the bowel nodule prior to its dissection from the posterior uterus and uterosacral ligaments. Next, we used blood and sharp dissection for development of the perirectal medial space to aid in isolation of the bowel nodule. Energy is used sparingly to minimize the risk of thermal injury to the nearby bowel and ureter. Ureteral lysis and development of the perirectal space was then performed on the opposite side using the same techniques. After developing both perirectal spaces, dissection was extended medially to develop the rectovaginal space. Based on preoperative imaging and the anticipated size and depth of the nodule, sharp dissection through the nodule was necessary to reach the rectovaginal space. Therefore, a portion of the nodule was left on the uterine torus and the rectosigmoid bowel. Following restoration of normal pelvic anatomy, a hysterectomy was performed. Surgical steps included takedown of the fallopian tubes and the uterovarian ligaments, effusion of the broad ligaments, development of the bladder flap, isolation and cauterization of uterine vasculature, followed by creation of the colpotomy. Care was taken to excise the entirety of the portion of the endometrial nodule confined to the uterus while preserving as much of the uterosacral ligaments as feasible. The cuff was then closed in a 2-layer technique using a barb suture in a running fashion. Any remaining uterosacral ligament remnants were incorporated into the vaginal cuff to facilitate proper suspension and support of the vaginal cuff. Following hysterectomy, the bowel was further prepared and mobilized by our colorectal surgery colleagues with development of the holy plane and exposure of the mesorectal fascia. A diverting ostomy was not indicated, as the resection was greater than 6 centimeters from the anal verge. A proctectomy was performed using a robotic stapler. The proximal aspect of the specimen was then exteriorized through the abdomen to allow complete resection of the endometriotic nodule and placement of the stapler handful. Bowel continuity was restored with an end-to-end anastomosis stapler in standard fashion. Following re-anastomosis, a flexible sigmoidoscopy was performed to directly visualize the anastomotic site with the suture lines submerged in normal saline to allow simultaneous air leak testing. Here we are able to see the direct before and after comparison. The final pathology was consistent with transmural endometriosis with 3 margins, and the patient had an uncomplicated postoperative course with resolution of symptoms. In summary, this case demonstrates the utility of the multidisciplinary approach to bowel endometriosis through a structured ultrasound protocol and perioperative flexible sigmoidoscopy for optimal surgical planning, excisional treatment of endometriosis, and patient care and outcomes.
Okay, now on. So it's time for questions and some comments on this perfect surgery. Yeah?
I think it's important to think about other ways we can try to have a better preoperative risk assessment of endometriosis that relies on imaging outside of MRI, which can possibly not be authorized by some insurance companies. Thank you.
Now we are moving to the next presentation. Will be presented by Dr. Samantha Kegel. The subject is the manifestations of vaginal endometriosis, robotic excision and surgical principles. Welcome, doctor.
Manifestations of vaginal endometriosis, robotic excision and surgical principles. Our objectives are to review deep infiltrating endometriosis with vaginal involvement and highlight pre- and post-hysterectomy manifestations of vaginal endometriosis. Vaginal endometriosis is a rare manifestation of deep infiltrating endometriosis. Mostly described in case reports, the true prevalence of vaginal endometriosis is unknown, but is estimated to be less than 1% of all endometriosis cases. Vaginal endometriosis can occur as a result of prior surgeries, where endometrial cells track through the vagina. In even rarer circumstances, vaginal lacerations during delivery can retain residual tissue, leading to vaginal endometriosis. Case number 1 is a 31-year-old G3P1021 who presented with a vaginal mass and constant daily bleeding for 2 years. She also endorsed fluctuating abdominal pain and intermittent abdominal bloating. MRI imaging done at an outside facility revealed a heterogeneous posterior lower uterine segment lesion centered in the myometrium, dorsal to the cervix and extending to the upper vagina. The patient was taken to the operating room for a pelvic exam under anesthesia and biopsy of the vaginal mass. Pathology revealed fragments of benign secretory endometrium consistent with endometriosis. The patient ultimately desired hysterectomy. Colonoscopy was performed preoperatively, as well as general surgery and urogynecology consultations. Upon abdominal entry, a normal-appearing 8-week sized uterus was noted with dense adhesions to the bladder and rectum. The posterior cul-de-sac was obliterated, with thickening of the uterosacral ligaments. A 4-centimeter friable glandular vaginal lesion was noted arising from the posterior fornix of the vagina. Ureteral stents were placed to ensure visualization of bilateral ureters. After completion of the superior portion of the hysterectomy, colpotomy was performed with care taken to avoid the vaginal endometriosis and the rectum. The specimen was removed vaginally. Next, enterolysis was performed to carefully dissect the rectum away from the posterior vaginal wall and the uterosacral ligaments. A partial vaginectomy was then performed to excise the entire endometriosis implant. The posterior vaginal repair was performed in 2 layers in an interrupted fashion. The vaginal cuff was then closed in a vertical manner to preserve vaginal length. Cystoscopy confirmed bilateral ureteral function. Flexible sigmoidoscopy was then performed with an air leak test to ensure that the rectum was not compromised. Post-operatively, the patient recovered well, meeting all milestones for discharge on post-op day number 1. Pathology demonstrated a cervix and vagina extensively involved with endometriosis. The patient was started on Elagolix for endometriosis suppression. Case number 2 is a 42-year-old G5P1041 who presented with vaginal bleeding post-hysterectomy. The patient described her bleeding as non-cyclic spotting that occurred up to 3 times per month. MRI imaging of the pelvis was unremarkable. The patient underwent in-office vaginoscopy, which revealed an approximately 1 centimeter area of raised nodular tissue consistent with endometriosis. The patient was unable to tolerate a biopsy at that time, but desired vaginal cuff revision. Upon abdominal entry, endometriosis implants were noted throughout the pelvis, including the posterior cul-de-sac, vaginal cuff, and peritoneum overlying the right ureter. Bilateral ureteral stents were placed in order to safely delineate the course of the ureters, and a vaginal manipulator was used to visualize all portions of the vaginal cuff. The endometriosis implants on the pelvic peritoneum were removed using a combination of blunt dissection and the monopolar scissors. Wide excisions were performed, particularly at the deep lesion on the right of the vaginal cuff and the posterior cul-de-sac to ensure that all deep endometriotic implants were removed. The bladder was backfilled to delineate this important anatomical landmark. The bladder was then carefully dissected away from the vagina to provide adequate tissue for revision. The cuff was noted to have multiple areas of fibrosis and endometriosis. These areas were excised with the monopolar scissors and sent to pathology. Next, a wide incision was made around the previous vaginal cuff repair. This defect was then sutured in 2 layers. Cystoscopy was performed and the ureteral stents removed. Pathology demonstrated vaginal tissue as well as pelvic endometriosis. Post-operatively, the patient recovered well and started on Relugolix estradiol norethindrone for further endometriosis suppression. In conclusion, these cases demonstrate 2 manifestations of vaginal endometriosis and techniques used for management and suppression. Ureteral stenting was used to enhance visibility at the time of surgery. Flexible sigmoidoscopy was used in cases with suspected rectal involvement. Wide local excision was employed to improve margin status and prevent recurrence. Careful vaginal repair was performed to ensure tissue integrity. And a multidisciplinary approach is crucial to improve patient outcomes and ensure adequate resection and repair.
Thank you for the presentation. Now, is there any question, comment on this?
I have one question. How did your team decide on using GnRH antagonists for both these patients for medical suppression versus other medications?
Yeah, thank you for your question. This is definitely individualized based on each patient, and a lot of times at our institution in particular, it's a struggle with insurance approval for some of these newer GnRH analogs. And it's just an individualized approach. Obviously, with the first patient we used, Orlissa, she's doing great on it, has no symptoms of recurrence. The second patient, she's on Myfembree, and also doing well.
Thank you.
Thank you very much for a nice video. One of the issues when we do this extensive dissection of the hysterectomy, there is small chance of rectovaginal fistula. Do you do anything like a mental flap to cover this area?
We did not in this case. That's a great thought and something to think about in the future. What we really wanted to do is a maximal safe resection without compromising the rectal wall at all. Maybe that contributed to our positive margin status in the first case, but mental flap is definitely something to think about.
Thank you.
Was the second surgery performed by GYN oncologist or was it a GYN oncologist?
The second case was performed by a mixed surgeon and urogynecology. The first case was by GYN oncology and urogynecology.
Is there any other? Right? Thank you very much again.
And our final video today will be by Rabachi, Seeing Deep ICG Fluorescence in Deep Endometriosis Surgery.
In this video presentation, we demonstrate the use of indocyanine green fluorescence imaging to enhance surgical precision and safety during laparoscopic management of deep endometriosis with bilateral ovarian endometriomas. A 24-year-old nulliparous woman presented with severe dysmenorrhea and recurrent emergency admissions. Ultrasonography revealed bilateral ovarian endometriomas. The sliding sign was negative, and tumor markers were elevated. Preoperative cystoscopy was performed. Identified right and left ureteral orifices. Through each orifice, a 6 French ureteral catheter was introduced. Then, 7.5 cc of indocyanine green was administered via both catheters. The cystoscopy lasted approximately 5 minutes. Following cystoscopy, laparoscope entry was performed. A 7-centimeter endometrioma was observed in the left ovary, and a 4-centimeter endometrioma was noted on the right. Dissection was initiated from the left pelvic side wall. During dissection, rupture of the endometrioma occurred. While aspirating the cyst content, adhesions between the ovary and the pelvic side wall were released. The posterior compartment was explored, revealing an obliterated Douglas pouch. The right ureter was visualized under ICG fluorescence, and the right ovary was freed from the Douglas pouch by releasing the adhesions. After partial mobilization of both ovaries, dissection of the left pelvic sidewall was continued. The left ureter was visualized under ICG fluorescence. To improve visualization of the dissection planes, both ovaries were suspended. The left ureter was safely dissected under ICG fluorescence imaging. An endometriotic nodule was identified over the ureter. Before excision of the nodule, a rectal probe was inserted to better delineate the rectal borders and ensure a safe dissection plane. Safe dissection of the rectovaginal space was achieved. Under ICG fluorescence, the right ureter was safely dissected. ICG off the field becomes complex and poorly defined. ICG on the ureter is clearly visualized. Following the dissections, the endometriotic focus in the right pararectal area was removed. The endometriotic nodule over the left ureter was also carefully and safely excised. The endometriotic nodule over the right secretory ligament was safely excised. Cystectomy of the left ovary was performed, followed by meticulous ovarian reconstruction. Cystectomy of the right ovary was performed, followed by meticulous ovarian reconstruction. The total operation time was 3 hours with an estimated blood loss of 50 milliliters. ICG fluorescence was still observed at the end of the procedure. The patient was discharged on the first postoperative day and achieved spontaneous pregnancy 10 months later. ICG-guided fluorescence imaging provides real-time anatomical mapping and improves surgical safety during deep endometriosis surgery by enhancing the visualization of ureters and critical structures.
Thank you for this excellent presentation.
Yeah.
So, other questions or some comments? I have a question to you. How often do you use this technique for your patients with endometrioma? or suspected endometriotic nodule?
First, I have special thanks to Professor Cihat for his mentorship and support. And this question, here he is here with us. Please.
I can answer the question.
Can we get a microphone, or you can use this one?
Okay. I start to use this ICG technology 6 years ago, and in some cases, not all cases, some complex cases, I use this technology. So, I think it helps the surgeon. I think it increases the time loss for the surgeon, because these surgeries is very complex surgeries, take long time, and continuous concentration of the anatomy navigation is exhausting. So if you use this, if you see the ureter always under your vision, so it makes surgeon, it makes this surgery easy, and so it decreases the surgeon's stress also. Yes, I am an expert surgeon. I can dissect this ureter very well. I know how can I dissect the ureter, but I think if you have this technology, also help the surgeon and make surgery easy, decrease the stress of the surgeon.
Thank you very much for the nice demonstration. Only one question about ICG grade, because we use it a lot in oncology for identification of the sentinel node. You have to be careful the patient doesn't have any allergy to iodine. Also, when you inject in the concentrations in the ureter, be sure that the patient doesn't have underlying ureter or kidney abnormality. The BUN and creatinine is normal. Also, I think your concentration is a little bit too high. 6 cc, maybe it is too much. We most of the time, we inject 2 cc and flush it with some saline, because high concentration has been reported, could cause damage to the kidney. Just want to give you some caution. The other thing is that you don't have to put the catheter all the way up too high. You put maximum 10 centimeters, but if you go too high, you may hit the kidney. I think your catheter, you went more than 15 centimeters. So I guess only a practical point that the purpose is to inject the ICG grade, and if you think that you are going to finish it less than 3 hours, you remove the catheter. Also be careful when you put it, be sure the patient doesn't have hematuria, because sometimes the patient has hematuria after putting the catheter, and then if the blood could occlude the ureter, and then you have post-surgery anuria. So these are the some practical points to keep in mind. Thank you.
Thank you for your experience. And yes, please, microphone.
I just want to let you know that in my experience, and I may not be as extensive as yours, but I do use stents in almost all cases just to be prophylactic against lawsuits. So I've used it for the last 30 years. I just one case had anuria for post-op obstruction, because if it's not hygroscopic, earlier Stryker did not make hygroscopic stents. Now most stents are hygroscopic, therefore they don't slide along collecting mucous membrane or urothelial endothelial lining, and they bunch up, and there's post-operative hypotension naturally, because patients have been bowel prepped and they don't have enough fluid. Once we give aggressive fluid, patients do urinate and then it pushes out the little mucus plug. That's what I learned because I did extensive research after the lawsuit. And it was not, it has just corrected itself and she was fine. And now, since the newer stents, we don't have these problems anymore. And I do use, as Professor Fatih does, stents. I don't use ICG, but I plan to use. It's a very good technique. Thank you.
Thank you very much. Thank you also for this nice presentation. Thank you for all. And the next session is starting now, and I'd like to invite the panel discussant to the stage first. And then we have an announcement for you. So you may go out and get your coffees, but there is no break at this time. So thank you very much.
Hi, everyone. Hi, good afternoon. I'm Kevin Smith. I'm the Associate Dean for Academic Programs and Affiliations at Morehouse School of Medicine. I'm a minimally invasive GYN surgeon. I trained with Camran and Nezhat 100 years ago at Stanford. I am extremely thrilled to be here and grateful to the Nezhat brothers for this opportunity, and particularly excited for them to make space for our panel, which is disparities in endometriosis, adenomyosis, and fibroid management, which we know is a real issue, and I applaud them for making an intention around having that discussion. We've hit on it a little bit here in the conference, but this is going to be speed dating. You know, this is a 30-minute presentation, and each of these guys are amazing and have lots of information. We've condensed it as best we can so that you have some sense of these challenges around disparities with regard to these, with adenomyosis, endometriosis, and fibroids. They're fantastic. I'm going to have them introduce themselves, and we'll keep ourselves on task in terms of time.
Oh, just. Oh, yeah.
Well, good afternoon, everyone. As Kevin said, we're going to really try to get this done quickly. We think we have a lot of information to give you, and we have no idea how it's all going to go through. So, I'm Robert Waugh. This is the one we sent in. All right, whatever. Was there the next one? No, this is the one I sent. Okay, it doesn't matter. Anyway, I'm Robert Waugh. This is not the title I wanted to have on here. Probably the best is I'm a former board chair and president of the American Medical Association. And I'm also a senior advisor at Health 2047, which is the AMA's Innovation and Venture subsidiary. And I'll talk more about that in a minute. What I thought we'd do as the beginning of this is talk not just about the racial and ethnic disparities, but really the global issue of women's health care in this country and a little bit of the history of that. So I just had a couple of slides on that. I think most of us here that have been involved in women's care recognize the problems that we've seen over the historical time frame, that women's research and healthcare has been essentially neglected systemically over time. And we start with research. Women were excluded from most of the studies that we have across all of healthcare, partly because of concerns about reproductive effects of research on women when they might be pregnant, but also a very paternalistic history of the male-dominated infrastructure that felt that they only wanted to study men over women. So I think we're all very familiar with that. The other one is the pain gap. It's well documented that women's pain is often disregarded at a higher rate than men's. There's a delay in being seen for pain. There is a less likely be treated for your pain if you're a woman over a man. And then things like the misdiagnosis of health diseases like heart disease. Women are twice as likely to receive an incorrect diagnosis after a heart attack. They're 2.5 times less likely to be referred for their chest pain than men, things like this. And then finally, the underfunding of women's healthcare problems. And I think that's where I'd like to focus a little bit of attention in where I think we're making some progress. So that's sort of painting the story of where we are. To catch up a little bit, things have happened, right? So in 1993, there was actually a federal law that said we now have to include women in NIH clinical research. And yet, it still takes a long time for that law to take effect, where they added another policy in 2016, where now researchers have to report specifically by biological sex how many participants they have in their studies. I think another encouraging factor is the rise of what they're calling femtech, or financial investment in women's healthcare. And I thought it'd be important to highlight this. It's growing 160% faster than the broader healthcare market. That's encouraging. It's got a lot to catch up, but 160% faster is great. $39 billion was invested in the femtech market in 2024, and we're expecting it to go to a $97 billion by 2030. There's been some focus on medical curriculum, where it's been said that medical students in their 4 years of medical school may have one lecture on endometriosis, even though 1 in 10 or more than that women are suffering from this, and it often takes 7 years to diagnose. We're all very familiar with that. Other policy that's happened very recently that I thought would be worth noting is in 2024, the White House Initiative on Women's Health Research wanted to make a $12 billion investment to close the research gap. That included $100 million for ARPA-H to accelerate commercial health products for women. And so, see, this is the wrong set. There's another slide missing here, and I apologize. At Health 2047, which is, again, the venture and innovation subsidiary of the American Medical Association, we started in 2016. It's placed in Silicon Valley, and our job is to facilitate and promote health investment in technology that will improve physicians' lives. And so since 2016, 10 years ago, we've started 13 companies, and we're pretty happy with that. And the other thing we're very happy with is that we advise, support, and connect innovators with the venture capital environment in Silicon Valley. And we also give them a little bit of money. Money's like 4th or 5th on the list. For every dollar we've invested in those 13 companies, the marketplace has invested 12x. So 12 more dollars for every dollar we put in to those 13 companies. Just 2 weeks ago, we released what we call our first investment thesis, which is an investment thesis about women's healthcare. And we believe that this is a very lucrative and very necessary area for investment to go. And I had a great slide in here about why we think this. And one of it is that investments in female healthcare has been much more lucrative than investments in other healthcare. It's 23 times more successful on exits and dollar-wise than general healthcare that's about 2x. So we're very optimistic that this kind of investment thesis will attract new investment and new entrepreneurs in this incredible, important space. And so I wanted to share that with you as an overarching theme for what we're going to talk about next. And I'll turn it over to the rest of my panel for more specific details. Thank you.
Hi, I'm Jeanette Lager, an investigator in the NAC Corps, which I'll tell you more about, and a MIG surgeon, and I'm honored to speak on community and student engagement to address racial disparities in endometriosis, adenomyosis, and fibroids. I'll be succinct. First, I'll summarize the problem with a few hard data points and then describe evidence that engagement and trainee involvement move the needle, and then I'll finally share how ENACT operationalizes these ideas into practice. The top one, okay. Perfect. These conditions, endometriosis, adenomyosis, and fibroids, cause significant pain, heavy bleeding, and infertility and quality of life for millions, as you've heard already. Importantly, this burden is not equal across racial and ethnic groups. For uterine fibroids, multiple lines of evidence show an outsized burden in people of African ancestry. Fibroids occur earlier, grow faster, and produce more severe symptoms. This translates into a higher utilization of acute care and surgery. For example, analyses note 3-fold higher hospitalization rates, 7-fold higher rates of myomectomy, and 2-fold higher hysterectomy rates compared to white patients. And these are not just numbers, they reflect work loss, fertility impact, anemia, repeat operations, and downstream complications. What about endometriosis and pelvic pain? In a large integrated health systems analysis, Black women were more likely to receive pain medicine and surgery, but were referred to pelvic health centers at lower rates, 14.9% versus 18.4%. This suggests that differences are not purely biological, but involve access, referral patterns, and possibly provider bias and system-level barriers. Adenomyosis is less often discussed, but similarly unequal. A US population study found a higher incidence in Black women, and among women undergoing hysterectomy for adenomyosis, non-Hispanic Black women had higher odds of major post-op complications and were less likely to undergo minimally invasive surgery. Those differences influence recovery, complications, and long-term function. But now for the hopeful part. There's accumulating and consistent evidence that community engagement, particularly community-based participatory research, improves the reach, relevance, and uptake of interventions in historically marginalized communities. Systemic reviews show deeper engagement, power sharing with community partners that increase program participation, retention, and often lead to measurable health improvements. Students and trainees are a critical resource here as well. Service learning, community-engaged curricula produce learners with greater empathy, better understanding of social determinants of health, and concrete skills to screen and refer for unmet needs. Programs where students perform outreach, co-create educational materials, have increased referrals to resources and improve access metrics, and they create a pipeline of clinicians who see engagement as part of the care rather than just an optional add-on. This brings me to ENACT. ENACT is a UCSF Stanford Endometriosis Center for Discovery, Innovation, Training, and Community Engagement. It's explicitly structured with both an administrative core and an education and community outreach core to connect rigorous science with community priorities. The center retains endometrial tissue, a DNA bank, outreach and dissemination, while also embedding students and community representatives in studies, outreach, dissemination. In practice, that means co-designing recruitment materials with community partners, offering student-led educational events, and creating bi-directional priorities, sharing with patients who've had lived experiences. So what can we do right now? For investigators, design studies with community partners from day one and report stratified outcomes. For clinicians, ask about access barriers and refer intentionally. And invite trainee participation in community research. For students, seek out community-based programs and service learning experiences and bring them back to your training programs. And for funders and institutions, invest in cores that support sustained community engagement. So to conclude, racial disparities in care for endometriosis, adenosis, and fibroids are harmful, but they are addressable. Community engagement and student involvement are evidence-based tools to narrow these gaps to create better science and better care. This is our group from the ENACT, which has been a great collaborative leadership with both students and community partners. Thank you.
All right, good afternoon. My name is Cihat Jr. I'm the Chief of Minimally Invasive Gynecologic Surgery at Long Island Jewish Medical Center in New York. And I'm going to give you a ridiculously abbreviated presentation about racial and ethnic disparities in endometriosis and adenomyosis. I left that little quote up there just as a reminder that this is from the Green Journal back in 1953, but unfortunately there's a little whispers of some of the ideas mentioned in this quote hold us back a little bit today with regards to endometriosis. So first of all, about diagnosis, this is a study by Humphreys et al. And we know although the likelihood of endometriosis did not differ by ancestry groups, the odds of a surgical diagnosis by laparoscopy was significantly lower for patients of African ancestry in comparison to European patients. That means these are patients who are less likely to go in for that diagnostic laparoscopy to evaluate chronic pain or what other symptoms might be associated with it. When it comes to adenomyosis, it was more common among African ancestry patients than it was among European ancestry patients. And that goes hand in hand with what we'd expect about the evaluation of abnormal uterine bleeding, and given the fact that adenomyosis is often discovered at the time of hysterectomy for fibroids, and as we know, fibroids are more common in patients of African descent. Non-white race is associated with delayed surgical diagnosis of endometriosis in adults. We hear this over and over again. Unfortunately, the same is true for adolescents. Capra et al. Found that in the adolescent population, Black patients were less likely, again, to undergo laparoscopy for diagnosis of endometriosis. They were also less likely to undergo non-emergent surgery. We'll hear more about this when Dr. Nezhat speaks later. For management, I wanted to just highlight 3 studies. The first, by Orlando, is a retrospective study looking at almost 12,000 patients who had surgery for endometriosis. Non-white patients were more likely to have a hysterectomy. And when they did have a hysterectomy, they were more likely to have the procedure done open as opposed to by a minimally invasive approach. Non-hysterectomy surgery was more likely to be open as opposed to laparoscopy. And non-white patients who were more likely to have oophorectomy, especially at a younger age. In the second study, Moawad et al. Performed a retrospective study looking at 5,600 patients who had hysterectomies for endometriosis. They found that endometriotic lesion location did not differ with race and ethnicity. That being said, race and ethnicity did have impact on surgical approach and concomitant surgical procedure. So Asian patients had the lowest rate of laparoscopic hysterectomy. White patients had the highest rate of concomitant surgery. So while they were going in for their hysterectomy, they also had endometriotic lesions removed, endometriomas removed. Black patients, as we heard previously, were more likely to have major and minor complications. The final study by Meyer et al. Is a retrospective study looking at 12,600 patients who had a hysterectomy, now this time for adenomyosis. In this population, non-white patients had an increased risk to undergo major postoperative complications, and non-white patients were less likely, again, to undergo minimally invasive surgery. So in what may be the most self-serving slide ever put together as a minimally invasive surgeon, this is a study by Schneier that showed that some of these factors that we spoke about earlier may not be true in patients who had surgery with a minimally invasive gynecologic specialist. Interestingly, stage 3 and 4 endo was highest in Black patients and lowest in white patients. Why would that be, you say? Because if you have somebody who has an endometriotic lesion and they're Black, they're not going in early, they're not going in until their symptoms have progressed to the point where they have stage 3 or 4 disease. So that kind of makes sense. They also found that there was no significant difference in perioperative complications in oophorectomy or in hysterectomy. I think it's important to note that the population for this study was about 95% privately insured, and a little bit we'll hear about how that contributes to disparities in healthcare. Thank you.
My name is Dr. Joel Sias. I trained with Dr. Camran Nezhat. If Kevin did it 100 years, I did it 101 years ago. So my section is to address disparities in pain management among patients with endometriosis. And I think it's going to mirror the broader issues about health access and how that impacts pain management. I'm going to do it in a very accelerated fashion because by popular demand, I've been asked to have Lily come back and demonstrate that beautiful AI tool that she's been developing with Asia to optimize the care for patients with endometriosis. And I think it's going to be relevant also for patients, minority patients. I spoke to Dr. Smith, who's working at Morehouse on improving the care for patients, minority populations, increasing the enrollment of, creating more physicians of color, because data shows that if you have a racially congruent pair, the patient and the provider, that outcomes are systematically better. So that's how he's going to change access to care and pain management for the next generation. But in the short term, I think we can say that the management of pain among patients, minority patients, it reflects the broader society in which these patients live, and that's going to lead to patients being undermanaged and undertreated. Part of the issue is that their assessment may not be optimal, and that means that their management may not be escalated appropriately, and they may be dismissed as pain-seeking. So this reflects sort of the systematic issues that sort of reinforce the patient marginalization and the fact that patients are not taken seriously. And so if we look at how that impacts the care, we have to look at it not in isolation, but the fact that it's representative of the broader society in which these patients live and in which the patient care is given. So as physicians, I think it's so important for us to be mindful of how the patient is living, not just as a medical case, but in the broader context of the socioeconomic factors that impact the care. So they maybe feel dismissed, marginalized, and not by not having the issues addressed. And so our goal is to make sure that we are aware of those biases and that we make an active effort to mitigate them. So let's see. And so I'm going to go ahead and, so this sort of says that our goal is to make sure that patient care and pain management is also reflective of the quality of care that we want to give our patients overall. Okay, so come on over.
Hi everyone, I'm back. I'm Lily. I'm 26. I started as one of Dr. Nezhat's patients. He was the turning point in my care of believing me, telling me my pain was real. And after working in the clinic with him and seeing a bunch of patients go through the clinic, including myself, I had a really intensive surgery and it was so well done, but I still had some residual pain after. And to me, that was signaling, as somebody who wants to go into medicine, loves this research and all of this stuff, there's something systemically going on. There's something that's a lot deeper than just this localized disease that's being treated localized in the abdomen, and it extends more than that. And there were plenty of patients coming through that wanted an answer, something else to do right after their surgery, and I just kind of got to the point, I was really tired of sending them away without an answer. And I think with this as well, as I mentioned before, I had the privilege of family support, of insurance, of education, to know what I was looking for, what I needed, even though it took a very long time to get diagnosed, but that's not the case for everybody. And I think that this AI tool that we're creating, if you want to put it up right now, we're going to just ask it a couple questions to kind of show you how we've tried to personalize this care. So the difference here is that we're using your actual patient data. So I have 5 other comorbidities. Those are included here. So right now, like this is something I wish I had, right? Like when I was post-surgery, I had a couple bouts of severe chest pain. I felt like I was having a heart attack. And I would have loved to have something in the middle of the night to chat with to see what was going on. So yeah, here you can put this up. And this would all be based on my profile. So this was based on my patient profile. But I think the big thing here too is just that everybody is a different case. And so that's why we would like to individualize it. But yeah, so can we... So she's just putting my information in here. This is basically how you would log in. This is just a sort of mock-up of it. But yeah.
So once you log into the portal, you will be directed to your patient portal. Once you get into the patient portal, you can upload your health records, which is right there. After uploading the health records, the AI is going to mull over it, figure out what are the aspects, that's how it's trained, right? What are the aspects it needs to pull out of the record to create a very intuitive response to what you're going to ask based on the inputs that we are going to give. And it's going to take in a lot of other researches which are verified by the medical practitioner and Dr. Sais right now. So I'm going to put in the surgery date. Lily, do you want to give your surgery date?
My surgery date was December 15th, 1995. That's my birthday.
You know that
is my birthday.
Okay.
And part of this too is there's a lot of times when you go to all these different providers and you're constantly trying to transfer your medical records, you have to tell your story again, which can be very traumatizing after a while. And then also just, having to list out all your meds again.
Yeah, so underneath that, under the procedures, we've got laparoscopic, deep infiltrating, excisions with bowel movement. So you've got a lot of things that you can click on if you need anything in detail for a specific procedure. So we're going to go with laparoscopic right now, and I'm going to click here, and it's going to start your healthcare. So here we have certain pain, the definite pain symptoms that you see, and for some reason it's not very visible, but I will try and make it visible. So you can go here and click at pelvic pain and increase the discomfort level from 5 all the way to 7 or 8, right? If it goes anything above 7, it will tell you that it's good to call your clinic, right? You can click multiple of them and then you can click bleeding, and let's do leg pain, leg swelling. So when you click leg swelling, it's intuitive enough to know that if you are telling her that there's a leg swelling, it could be because of the blood clot. You can increase the discomfort levels for as high as you want to go. And then we're going to analyze the symptoms here, which Lily will analyze and let you know what this means.
So this is the output here. And then for the sake of time, I would just like to ask it a few questions to just show you sort of the advancements we've made. So one of the questions I wanted to ask was, why did my surgery last 5 hours?
Let me cross-reference this with your records and recovery timeline. What would you like to focus on first?
So Lily did read through the entire thing that we had put in. And I don't know if you can see this. Okay. And then, Lily, do you want to ask it a question? Do you want it to answer all the symptoms and why it's having? Should we say all?
Or just maybe surgery time? Like, what is the significance of my surgery time to my case? And then what should I expect maybe as a post-op patient? Just say based on my surgery.
You asked, what should I expect as a post-op patient based on my surgery? Also talk about the symptoms.
It's taking a little longer because the API is on a local host. It's not in production right now, so it has to go through multiple files to get the right answer.
Once it comes out, yeah. But the idea too is to try to reduce some of the burden on clinics because, there's a lot of calls that come in. There's not a lot of time. There's a lot of patients to see. So, yeah, here we go.
Lillian, let me pull up everything I know about your surgery and walk through what your body has been through. And then we'll talk honestly about what you logged today. Is your surgery. What actually happened? On December 15th, 2025, Dr. Camran Nezhat performed a complex multi-hour surgery at O'Connor Building Surgery Center. This was not a routine laparoscopy. Here is what was done. Excision of stage 4 endometriosis involving multiple organs. This is the most advanced stage. Large dermoid cyst removal from your left ovary, 9.6 centimeters, with significant adhesions to your bowel, bladder, and ureter. Complete posterior cul-de-sac obliteration was found and treated. Bilateral ureterolysis. Your ureters were carefully freed from surrounding fibrosis and endometriosis. Bowel work. Adhesions were separated, denuded areas were sutured. Hysteroscopy. A polypoid endometrial lesion was identified. Appendix. Was found tortuous and hyperemic, pulled toward pelvic structures. Nerve-sparing technique. The inferior hypergastric plexus was carefully preserved throughout. This surgery touched your ovary, bowel, bladder, ureters, peritoneum, pelvic sidewall, and nervous plexus. That is a significant amount of internal work. I don't know. What to expect at day 19? For your surgery specifically. Because of the complexity and scope of what Dr. Nezhat treated, your recovery is not a standard 2-week laparoscopy recovery. Here is what is realistic and expected at this stage. Expected and common. Ongoing pelvic discomfort and achiness. Your pelvic anatomy was significantly reworked. Fatigue that comes in waves. This is your body allocating energy to deep internal healing. Bloating and GI changes. Bowel work was performed. Your gut needs time to settle. Hormonal fluctuations. Your ovary and pelvic environment was significantly disturbed. Emotional ups and downs. Completely valid given the physical and hormonal shifts happening. Worth watching.
Yeah, so we're short on time, but I just wanted to kind of show all of this to mainly show that this will treat you as an individual patient. It's not going to give the same advice to everybody, and I think that could be really powerful, especially for people that have a lot of barriers to care. So thank you for giving us your time.
We're going to put the last set of slides up. I will move very quickly to describe, oh wow. Quicker. Racial and ethnic disparities in fibroid management. Thank you for that. That was awesome, Joel and Lily. You all know this. Fibroids are more common in Black women. That's probably not the biggest issue. The bigger issues are what's in that middle column, what's in the bottom, what happens to Black women with fibroids. Surgically, non-surgically, when do they happen? They're more excessive, more extensive, happen earlier. Treatments are a lot more morbid. I'll try to keep moving. The question is, why? Why is this going on? This human myometrial stem cell hypothesis suggests that there's stromal mutation of these myometrial stem cells. This is an older study, but what you can see here is in Black women, you have more of these stem cells in the myometrium where there's fibroids, and versus white women, although they exist in both, and the percentages are higher. The other thing you find is that there are relationships to hormone impact, so proliferative versus secretory parts of the cycle. There's another study that describes differentiating, expressing genes that are more common in the myometrium of Black women. And so what studies like this, and you'll find others if you look, are suggesting is that something's happening in the myometrium for Black women differently than for others. But we all know it's not the true, complete story, right? So this is a systemic review of many, many studies, and it describes many of the touch points that lead to these outcomes. These glasses are good, but not great. But I have a sense of what this is trying to say, which is generally that there's so many issues associated with being a Black woman in this country or in this world that lead to these outcomes, including racism, and Dr. Osai has talked about racially concordant care and what's the impact there. What's your health access in your community? What's your nutrition status? We do know that nutrition affects fibroid growth. Weathering is listed there, kind of hidden in the middle of that slide there, but it describes longitudinal impact of all of these social determinants of health. And then what happens with the actual care and impact on outcomes once they kind of get through that hump and get diagnosed. This is pretty interesting. And our AI twin that spoke yesterday, Ms. Jones, we had a quick talk about this yesterday. This is independent of financial access, financial status. This study is the doctoral work of Dr. Cheryl with Kiskombe, who was doing her nursing doctorate. And what she was able to do is survey Black women who were on tenure tracks at institutions of higher learning. And what she found was this superwoman schema that I'm sure your patients will tell you about, where they just have to endure certain things. They're just not going to stop on their track. They're not going to take a break. They're not going to go to the doctor. They're definitely not going to stop and do 4 weeks of surgery. How many times have you had a patient, I know I had it probably last week, where they definitely need surgery and all they're concerned about is how long am I down? How long am I down? Like, that's so secondary, but it's not in this particular schema. So Black women, particularly those who were highly educated, presuming then some access, reported excessive work habits, having to postpone their medical care, and feelings of fatigue. This is another part of the disparity. So one of the women who was surveyed, her name, she was a doctor, and she had surgery for her fibroids, she had a myomectomy, but still suffered with endometriosis, and she was bound and determined to tell coworkers and other women, don't delay your care. And this is what she said after her surgery for fibroids while still suffering with endometriosis pain. Well, it hasn't necessarily impacted my productivity. Sometimes if I can't sit up straight because it hurts, I can back out a little. I can call it my napping couch, my office couch. She's still suffering. She's still suffering. So here are some outcomes some data that has been touched on by many folks on the panel today. Dr. Eve Zawitsky, who I know many of you know, did this work in 2022. Essentially looked at 4,000 patients in the Kaiser system and basically found that Black women were less likely to go under a minimally invasive myomectomy versus other women. And on the right side, near and dear to my heart, since I work with the Atlanta VA population, this first study of 1,255 veterans showed that 61% of Black women and 39% of white women had abdominal hysterectomies versus a minimally invasive approach. And that ultimate review showed that 99 of those probably didn't have to happen now. Yeah. And here's another review of a recent one. So the point is that this isn't necessarily changing as quickly as we would like, and the outcomes are basically the same. So here's some encouraging news. This Co-Equal Center, which is starting at Mayo in Florida, University of Florida, and University of Mississippi, is really a center bound and determined to assess early risk factors for fibroids, impacts on fibroid management and treatment for patients, and create some mitigation of these disparities in a proactive and longitudinal way. And this just started in January. I have every intention of reaching out to them and asking if I didn't call Morehouse School of Medicine, but we will circle back to that. And that was record time. I don't know how much time we have, but if there are questions, this is a very esteemed panel, very accomplished. I would avail yourselves of this opportunity.
This question is for Dr. Wah. I'm in New York City, and as you know, that interact very well with MSS and wives, Medical Students of New York, and delegates finally went to AMA. Delegates, I think one was Dr. Mehta, Parag Mehta, you might know him, and so I was deeply involved in women's task force with MSSNY. And while we are just working on complex ideas of advancing women's healthcare with women physicians, there have been pop-ups, as you might know, of people who are not directly or trained for hormone replacement therapy, but now popping up everywhere, opening up menopause medicine, because there's a gap. You must be most aware of that than any one of us. There's a gap in menopause medicine because of the scare of cancer, and we still are afraid of giving hormones. Many people resent hormones, and they need it, and we discuss it. It requires 4 visits before they decide about menopause. In the meantime, they don't mind going to a person, a medical director who really doesn't sit there, but maybe some para or other healthcare providers are there who give menopause medicine without really caring for it. How did I know about it? I was called by a person from Atlanta, which is not devoid of physicians. And this was an intern. And he said, would you be a medical director? Because I want to start a menopausal medicine. I said, but how can I assess this kind of patient without actually examining, doing some workup? He says, well, yes or no? I said no. So that's what happened, but I was wondering if you can comment on that.
Yeah, I mean, there's a couple of things there. First of all, there are a lot of activities at the American Medical Association that I'm proud to say were promoted by your delegation from the American College of Obstetricians and Gynecologists. So we have a House of Delegates that creates the AMA policy. It's 750 doctors from around the country, and they're sorted by geography, specialty, mode of practice, and career stage. So we think we cover 99% of all physicians in the country, have some sort of representation across those 750 people. ACOG has 14 delegates out of the 750. California has 60 delegates because there's 60,000 AMA members in California. So that's the way it works out. Every 1,000 AMA members gets a delegate in that house. So to your point, we were very influential as ACOG in saying we want a commission that's broadly convened by the AMA, of AMA members, but also other components of healthcare, to look at access to healthcare by women. And that work group came together. One could argue that their product has not been exactly what we wanted, but it was a process that we started at ACOG. We took it to the AMA, got the women's healthcare issue amplified on a larger stage with a bigger microphone, and brought attention to the fact that women are having access problems to healthcare in this country. Your other question, I think, was about scope of practice. So who should be delivering care to our patients? I think we all agree that our goal is to get our patients the best possible healthcare they can possibly have. In general, historically, it's been a physician that's been sort of the captain of the ship. I served 23 years on active duty in the Navy, so captain of the ship is my way of saying somebody has to run this thing. So captain of the ship principle has been part of healthcare for a very long time. But as you point out, who's the crew members of that ship has been changing over time, and how much responsibility and autonomy the various crew members have has changed over time. And I will tell you that the American Medical Association is very, very sensitive to this, and we have a whole group focused on scope of practice. And we get it from our state medical societies that tell us of activities that are happening that may not lead to the best possible care of our patients. And so what you're pointing out, New York has done it, Georgia's done it, Texas has done it. There are optometrists, the people that fit your glasses in Texas, that are applying to use a laser on patients without any supervision from a physician. So your comment about lower level practitioners providing menopause care without direct supervision. That's part of the problem that we're seeing across all specialties. It's not just women's healthcare, but like I said, the idea that somebody who fits your glasses will fit your glasses and then take you in the back and operate on you with a laser without any physician supervision is a big concern. But it's something that we're actively working on, and we're getting input from all the state and specialist societies that make up that 750 delegates in the House. We're not 100% successful, but we're doing a lot in that area. We testify and advocate for captain of the ship kind of structure in state legislative processes, because that's usually where it happens. A state legislative process where there's a state initiative to give physician assistants the ability to write prescriptions for hormones or give injections, or optometrists use lasers or things like that. Those are all happening at the state level, and rarely does it make it to the federal or across the entire United States level. So we're very focused on the state level to make sure that those legislative processes are going to lead to the best possible care for our patients.
Hi, Kevin. This question is for you and probably the other esteemed lab physicians there. This issue of racial disparity in brain fiber and endometriosis and other women's reproductive condition is not new. What are certain strategies that you're implementing, utilizing the National Medical NMA to disseminate information, partnering with advocacy group, women advocacy group in these areas to sort of bridge the gap in awareness, reduce this disparity that you're so well described?
Well, I'll start. I think it's the last question, by the way. We'll move quickly. The NMA is really designed to address disparities. And I think the ways we do that are empowering patients, but also work that I'm doing specifically is growing the community of concordant care providers that patients can feel comfortable relating to, that patients can be diagnosed in a more timely fashion with. So I think it's creating that resource for them, maybe from your standpoint, Jeanette.
Yeah, I think one of the things that's been really great is to engage community partners. So ENACT puts on a screening and a panel of researchers. And what we like to do is we present the ideas that we have, and we meet with both students and with community patients to get their opinions and input on what we should be covering, what would be important priorities. And I think that those things together help us to build better care models that meet all of our patients' needs and hopefully help to decrease the disparities.
And in the interest of time, the only thing I'll add is that communication is so important. And so I think it's helpful to extend that ring to include our pediatricians. Because as we hear, adolescence, I mean, this is where it begins. And it is uncommon for me to see a 17-year-old who I'm going to then diagnose with stage 1 endo. If I'm seeing her at 17, it's too late. And our pediatricians, I think, need to be part of the conversation so that they're educated to look for symptoms and encourage further evaluation at least.
My last question is probably just for the audience. Are we concerned about AI fantasizing about potential treatment? It's like GPS, it can lead you down to a dead-end street. At times, you think there's a street and there's no true way there. Are you concerned about the fantasy, how AI can fantasize about a particular treatment when there's no treatment there?
Isn't that about kind of what you put in? AI sort of relies on what we upload. Go ahead.
I was just going to say, I think one of the common things that we're seeing in AI now are what they refer to as hallucinations. So it's not whether or not the data is correct or the algorithm is correct, they just frankly hallucinate. And so if you remember, what AI is trying to do is take a bunch of experiences and infer what the next thing is going to be. It's predicting what the next thing is going to be. And that's very hard, and it's very much dependent on the richness of the data that it's given and the algorithms that it's given to use to analyze that data. So if you understand those are the two components that make that prediction of what the next thing is going to be, whether it's the next word in a sentence or the next treatment that it is suggesting, there's room for what they call hallucinations, which is an error that the system makes in using that data and using those algorithms. And so these hallucinations are something that is very, very well known and very focused on right now, and they're trying to lower the incidence of them, but it's not zero. And so at the AMA, I'm just putting on my AMI hat over and over here again, we refer to AI not as artificial intelligence, but augmented intelligence. We believe it's a technology that should help physicians take better care of their patients. It should not be artificial like saccharin or some chemical that replaces sugar. It should be something that helps a physician take better care of their patients. And that means physicians are still, importantly, part of the loop. There's no time when you turn over patient care directly to AI. There's another concept in AI called human in the loop. We believe there should be a physician in the loop at all times, so that this technology is not autonomously, without any input from a human, trying to take care of patients. But it should be there to help doctors take better care of patients.